All right, picking up with the second half of this video, we're going to look at chapters 55, medications for dysrhythmias. So what you're looking at here is a 12-lead electrocardiogram. So basically, we put a whole bunch of sticky leads on the client's body, from their arms to their legs, and their back and their anterior chest, and we're able to view the conduction system or the electrical signals traveling through the heart muscle that actually give us an indication as to whether or not the muscle is pumping appropriately. So you can spend more time learning about that in later theory classes, but this is a useful diagnostic tool. So, as nurses, you'll become familiar with what the normal EKG should look like, our PQRST waveform. You'll recall that the up in the the right atrium is our SA node. That is the pacemaker of the heart, responsible for conducting the pulse or the electrical beats that should range anywhere between 60 and 100 beats per minute. That sends a signal through the atria to the AV node or the atrioventricular node. It has a brief pause there, and then it allows the electrical signal to travel down the Purkinje fibers to the ventricular muscles, which then cause a contraction and a pumping of the ventricles. So that puts basically, let me show you up in here. The left ventricle is responsible for projecting the blood out of the heart and to the rest of the body. We talked about the blood that leaves the left ventricle and goes into the aorta and goes into all the other areas of the heart. We drew that on the board in class. So I'm not going to spend a lot of time here, but the only thing I really want to stress is that the heart, the electrical system of the heart, just like the electrical system of your house, can become faulty. And so if there's any delays in the conduction or breaks in the fibers that transmit the electrical signal, that can become a problem in the conduction or the pumping of the heart, and we experience what's called a dysrhythmia or an abnormal irregular heartbeat. These can be benign, meaning the client doesn't even know they have them. They can be asymptomatic, particularly if they happen in the atria, or if they happen in the ventricles, they could be life-threatening. So this could kill someone. And in this case, we would apply a defibrillator, or we might apply medications to slow down or cause the heart to go back into a normal sinus rhythm. One of those rhythms that is very lethal is ventricular tachycardia. So you learn this in CPR. If the clients can have a pulse with ventricular tachycardia, or they may become pulseless depending on how fast the heart beats. So we'll spend a lot of time talking about that. That's more for your theory class. Let's talk about the medications that work on the conduction system of the heart. Again, we've spent time talking about beta blockers. These are the medications that end with lol. So you can put this on your beta blocker sheet. Hopefully you've done different categories on different sheets of your medication templates. So a beta blocker might be prescribed for high blood pressure. It could also be prescribed for angina. It could also be prescribed for an irregular heartbeat or dysrhythmia. There's nothing new here. If we've talked about one beta blocker, we've talked about most of them. So again, you should be able to fill this in pretty much by yourself. You would hold this medication if the heart rate was less than 60, or the client's bradycardic, or you would hold it if the blood pressure is less than 100 systolic, or the client's experiencing hypotension. You'll want to check these two vital signs before you administer this medication. I'm going to move on because we've spent significant time talking about beta blockers in this. Potassium channel blockers are very similar to beta blockers, but they work on a different area of the heart. This is a new medication, so I will pause and spend a little bit of time talking here. Quite often, clients can experience a dysrhythmia known as atrial fibrillation, or some other resistant ventricular tachycardia, or a fast heart rate. So we try a number of different medications. The medication that we're talking about here is a potassium channel blocker known as amiodarone or cardarone. This is a cardiac med. So the first thing that I want to stress is this medication cannot be missed. This medication must be given at its scheduled time. It can't be given early, it can't be given late, and if you forget a dose, you can't double up on this medication. That would be extremely dangerous to your client, potentially lethal. So what it does is it blocks the potassium ion channels from entering the myocardium. I don't really want you to learn that, to tell you the truth. What I want you to learn is it's a blocker. So it slows down the heart rate. I want you to hold this medication if the heart rate is less than 60 or the blood pressure is less than 100. The other thing that I want you to appreciate with this medication when you review your research in the drug book is that it can be very dangerous to your clients over time. Usually if they're on this medication, they're on it for life or a very long time. So we need to monitor their liver, we need to monitor their lungs. This can have toxic damaging effects over time. You'll notice here under adverse effects, pneumonia-like symptoms. So if your clients are experiencing pneumonia-like symptoms, that might be a reason for your doctor to order a pulmonary function test. If they experience blurred vision, this could be signs and symptoms of hypotension or heart block. If they experience any photosensitivity, that's sensitivity to light. If they want to wear sunglasses, or if they're finding that the sun or bright lights are causing them a headache, that's a concern. Also, nausea, vomiting, and anorexia, again, could be related to electrolyte imbalances and hypotension and bradycardia. So in your first column, you need to monitor the heart rate and the blood pressure prior to administering this medication. And under health teaching, these are all the symptoms that you need to watch your client, or you need to teach your clients to report to the doctor. So before this client leaves, they need to be able to state these things to you, that they understand. I have any nausea, vomiting, or loss of appetite, or any dizziness, or when I change positions, or any blurred vision, that I need to see my doctor right away. It could be a sign and symptom that this medication is toxic or actually causing me harm rather than helping me. This is a category C medication, so do not use during pregnancy or lactation. Avoid exposure to light or sun. They can have skin pigment changes. To take this medication with food because it is hard on the stomach. Oh, sorry. Calcium channel blockers. Again, another medication. This works on the electrical conduction system of the heart. Calcium channel blockers we have talked about in the past. These are the medications that end with Zem, Pine, and Mill. You remember me talking about that on the board. Zem, Pine, and Mill. So these medications are also used for dysrhythmias and anginas. So not only do they help relax the smooth muscles of the arteries, they also slow down the conduction system of the heart. So again, they slow down that electrical impulse through the heart muscle. So therefore, we'd be watching out for a bradycardic episode. So you would hold this medication if your client's heart rate is less than 60 or their blood pressure is less than 100. Again, heart failure is a progressive disease, and if your clients are experiencing any worsening of their symptoms, they may require further titration of their medications. We're looking for edema in the lower extremities. This could mean that the heart failure is getting worse. And if they have any palpitations or shortness of breath, again, they need to report this immediately to their doctor as well. So one other thing, do not give patients on calcium channel blockers any grapefruit juice. Grapefruit juice has the potential to cause toxic episodes with calcium channel blockers. So Zem, Pine, and Mill should never be given grapefruit juice. You could cause your clients to go in toxicity. So you'll want to teach them that. And I'm sure that was in your drug guide book. All right, so the nursing process for medications on dysrhythmias. You really want to check their heart rate before you give any medications affecting the heart. The doctors will order baseline EKG and look at the impulses of the heart to make sure that the walls are all moving appropriately. If your clients experience any hypotension or bradycardia, these medications should be used cautiously or potentially placed on hold, and the client should be evaluated by their doctor. Clients should be able to identify why they're taking this medication. A number of times clients will come into a doctor's office with their list of medications, and they should be able to tell you that that's my blood pressure medication or that's my heart medication. They shouldn't tell you that that's my potassium channel blocker or my sodium eliminator. They should know the basics of these medications and why they're taking them, and they should know that they shouldn't miss a dose, double up on a dose. This can be life-threatening, and they should know the signs and symptoms to report or when to seek medical advice. So that should all be captured in your health teaching notes on the final column of your medication template. Ultimately, we hope that clients experience an improved cardiac output, so basically that their blood pressure is normal and that their heart is resting. And that the client can identify why they're taking this medication, and that the rate and rhythm of their heart is between 60 and 100 and regular or at their baseline. So Moving forward, the last few slides talk about lipid disorders or cardiovascular disease, hypertension, and lipid disorders. So the medication, much like heart failure, hypertension can be a progressive disease that gets worse. A lot of people are asymptomatic, meaning they don't have any symptoms, so they actually don't know that their blood pressure is high. This leads them to experience hardening of the arteries, known as atherosclerosis, as well as heart attack, stroke, kidney problems, potentially requiring kidney transplants, and peripheral vascular disease. It's more prevalent in men until the age of 55, but after the age of 55, women tend to develop hypertension. The prevalence of high blood pressure increases with age. So the older you get, the more chances you are of developing high blood pressure. Canadians of African and Aboriginal descent have higher prevalence of stroke, heart disease, and end-stage renal disease compared to their Caucasian counterparts. And hypertension is sometimes more prevalent with less educated individuals, maybe because they potentially earn a lower income, or because they may not seek medical treatment for whatever reason. So, but nonetheless, every human is at risk of developing hypertension. And so what's important for you to appreciate with your theory class is the modifiable risk factors and the modifiable risk factors. So modifiable risk factors include things like your diet, the nutrition, smoking, caffeine intake. Your non-modifiable risk factors that you can't do anything about, your genetics, family history, growing old, etc. Those things you can't change. But the other things, hypertension, we try to encourage clients to make lifestyle changes prior to starting them on medications. So important for you to recognize that with the Canadian cardiac guidelines for hypertension, clients need to have their blood pressure screened annually or with every doctor's visit. And if we notice that their blood pressure is higher than 140 systolic or 90 diastolic, then we have them rechecked. Because you can't just make a client, they don't get a diagnosis of hypertension with one elevated reading. That could be falsely elevated for stress or illness or other reasons. And so they need more than 3 readings, with their systolic blood pressure being greater than 40 or diastolic blood pressure being greater than 90. And we encourage to make modifiable lifestyle choices first. And if that's not effective in reducing their blood pressure, then in order to prevent them from developing heart and stroke, we'll potentially place them on low-dose medications of the categories we talked about in the earlier video. 2 types of hypertension are primary and secondary. So primary, there's no evidence of any other disease or cause. This is the #1 or majority of cases. Secondary hypertension it develops as a result of an underlying problem like kidney disease or some sort of a vascular problem, such as like not an aneurysm, but coarctation of the aorta, etc. So common signs and symptoms that patients will complain of are increased headaches, dizziness, facial flushing, potentially confusion. Yeah, so those are all things that we need to be watching out for as nurses. Again, just reviewing your lifestyle modifiable risk factors here. You can read that on your own. Moving forward, the first drug that we're going to talk about for cardiovascular is a category known as statin. This is Lipitor or atorvastatin. So what it does is it lowers your LDL. LDL is your lousy or your low density lipid. I know I'm going fast, and so I'm going to pause for a second. If you don't understand cholesterol, spend some time looking it up in your book. There are 4 different levels that we monitor with cholesterol. We monitor your HDL, that's your high density lipids. We monitor your LDL, that's your low density lipids. We monitor your ratio and your total cholesterol. So those are important numbers. You won't need to know them for the sake of this test, but I think it's important for you to understand them when you're talking to a client. So a quick way for you to remember, this medication lowers the bad cholesterol. We call low density or LDL the bad cholesterol, because what that does is it sits in the arteries like cement, and it hardens the arteries, and it reduces the lumen diameter. So basically it increases blood pressure. What we really want is your HDL to be high. So maybe you want to pause this video and write those notes down. We want your LDL low. So your LDL needs to be low. It's your lousy, lazy good cholesterol. And we want your HDL to be high, your healthy, happy, housekeeping cholesterol. The only way that you can elevate your HDL is by exercise. And the only way, well, the multiple ways that you can reduce your LDL are through diet, but also if diet's not effective, then you may have to be put on a medication known as Lipitor or another statin-like medication. If clients are put on Lipitor, they need to have their cholesterol checked and follow-up screening. And we also want to watch out for their liver. This medication is hard on the liver, so hopefully you remember your liver labs. We're also looking out for any kind of diarrhea, constipation. Again, rarely, but it does happen. Liver damage may happen, so you need to be watching out for those liver labs and signs and symptoms of liver failure. Okay, usually this medication is taken at night. Watch for GI upset, never given to pregnant or breastfeeding moms. And again, the goal is to lower your LDL. And by lowering your LDL, we reduce your chance of developing a heart attack or a stroke. But quite often we encourage people to modify their lifestyle first before putting them on this medication. Another medication that can lower your cholesterol or your LDL is a bile acid resin. And the one that we're going to look at is cholestyramine or colchicine. This is sometimes used in gout, but it also has another property. It lowers your LDL. And so your liver plays a very important role in regulating your cholesterol. So basically any excess fat that you consume or sugar that you consume gets converted into cholesterol. So very important for clients to be aware that excess sugar and fat get converted into cholesterol. Adverse effects of cholestyramine or colchicine, constipation, severe nausea, potentially projectile vomiting, and other drug-to-drug interactions. So this is a medication clients don't like to take because we usually take it, it's a liquid quite often, and it's not a good tasting liquid. But anyway, so this medication, again, lowers your lousy, low-density lipid and doesn't do anything for your HDL. HDL is only raised by exercise, so keep that in mind. I'm not going to spend any time talking about this. This is your final slide. You can look this over. If you have any questions, please post them on the discussion board.